Thank you, Preeti, and also uh, good afternoon to all of you, and welcome to the third this technical session 3C, the third technical session of this parallel session. The session is on morbidity and mortality during pandemic and non-pandemic period, as already announced by Dr. Preeti. Dr. Harihar Sahu will be the discussion and rapporteur will be Salini Sen. And since all the presenters are available except for the fifth Rinshu, they can join later on, and accordingly we will allot them their time. Just a few words before we start. I think each of the presenter will be given maybe up to 12 to 15 minutes so that we have enough discussion on each of the papers. After the presentation, Dr. Sahu will be giving us his view on the papers presented, and I would request all the people attending to note down their queries for each of the paper, and then if possible you can upload on the chat. Otherwise also please note it down, at least one or two questions for each of the paper, so that they can improve upon, as well as if there are any doubt or any clarifications required from the papers, that can be addressed at the end. And I would say that the theme of this technical session is very relevant. If you are aware about the COVID situation, as of yesterday, the WHO has given us the confirmed cases of 120.9 million confirmed cases, of which 2.6 million have already died till yesterday. And similarly, in case of India also, we have already 11.4 million confirmed cases, out of which the number of death is already 1,59,000 or so. Therefore, the good news is that the vaccination has already started, and in case of India, over 34 millions have been vaccinated, and hopefully in the next few months or so, maybe at least 50 to 60% of the population without any age restriction could be vaccinated. And that is one of the demands of the many people, that without any age bar, if vaccination can be started for the public also. Therefore, the bad news, or the not so good news, is that in Maharashtra particularly, we have heard that the second wave is already starting, and that is what the BMC and others are already giving us, and hopefully we should be able to contain the spread of the COVID. Therefore, the public is again reminded of the protocol those required, particularly wearing of the mask and social distancing, as well as regular or frequent washing of or sanitizing the hands and hands. So those are the things that we need to keep in mind. And I'm happy that out of the 5 papers to be presented, 4 are directly related to COVID in different aspects of the COVID. And the 5th one, that is Rinshu, and Rinshu would be addressing a little slightly different, that is on the whether communication is the key to good health or not. They will be looking at depressive symptoms and associated morbidity during the pandemic, but they didn't specify whether it's the COVID or any other pandemic. So with these few words, I will request Rashid to present first. The title of his of their paper, Rashid Pawan and Suryakan Yadav. The title of the paper is Multi-Morbidity and Severity of COVID-19 Disease. So over to you, Rashid, and try
Thank
to
you, sir.
present in 12 to 15 minutes. Okay, thank you.
Sir. Is it visible to everybody?
Yes, yes, it is visible. Go ahead, go ahead. Yes.
Yeah. So good afternoon, everybody. So I'm going to present here my topic. How can I minimize it further?
Accept. Just press accept.
Okay. Yeah. So now I'm going to present my topic multimorbidity, severity, and COVID-19 disease in India. So give me one second.
Yes, go ahead, go ahead.
Yeah, actually, my one up and down is not coming actually.
Minimize the PPT. Just close the slide show mode. Just a minute. I am just again share the PPT.
Okay.
Now share the PPT file again.
Yeah.
Okay, now check. There is a button in the left side corner down. You can just move their mouse in the left side of corner. There is a button.
Yeah, got it.
Yeah. Okay, sir. Okay.
Yeah.
Okay, sir. Continue.
Now I'm going to present my topic multimorbidity, severity, and COVID-19 disease in India. The background is today one of the biggest health challenges worldwide is pandemic caused by novel coronavirus causing COVID-19 disease. The number of total cases of the coronavirus disease continues to rise quickly, threatening the thousands to millions of individuals with pre-existing chronic conditions who are disproportionately affected. The unadjusted case fatality rate of COVID-19 at the world level is calculated at 2.1%. This mortality rate shows a varying pattern over the different age groups, higher in old and adult age group, uh, uh, and then the adolescent and child age group. These statistics become important because the consequences of the COVID-19 disease were publicly known and that in short time. This makes the COVID-19 pandemic one of the public health problem with meaningful impact in the history of humanity. Comorbidities are more prevalent in older ages in adult ages. Nevertheless, the gradient of non-communicable diseases slopes up at adult ages. Old ages taken together with the adult ages makes a wide range of age group vulnerable to the risk associated with the severity of COVID-19 disease. Generally, the patient with the compromised immune system are considered to be particularly vulnerable. Most of the deaths are believed to be associated with the existence of comorbidity. As research related to potential risk factor for the COVID-19 severity and mortality continues, it is becoming clearer that individuals with underlying comorbidities such as cardiovascular disease, hypertension, diabetes, congestive heart failure, cerebrovascular disease, kidney disease, etc., are at high risk of adverse outcome. Now, need for the study. The demographic and the epidemiological profile becomes very crucial in the pandemic time. Many European countries faced a high case fatality rate as large proportion of aged persons were at the high risk of COVID-19 disease. It is important to understand the demographic composition and the epidemiological stage of a region. This can have a huge utility to understand the complexity of many populations which are different by regions to tackle the pandemic of COVID-19 disease and its consequences. Older age comorbidities, particularly the high prevalence of non-communicable diseases, are the risk factor for the severity of COVID-19 disease. However, the risk factor for the severity and mortality have not been sufficiently investigated. Determining the risk factor to anticipate the severity of COVID-19 are essential for efficient resource allocation during this pandemic. The objective of this systematic review and meta-analysis of hazard ratio and odds ratio from peer-reviewed article aim to understand the risk and effect size of multimorbidity, specifically 13 diseases, on the severity of COVID-19 and disease. The systematic review went, we access the work of literature from the database like PubMed on the basis of term coronavirus COVID-19 in all fields. It shows at almost 2,500 articles with COVID-19 in the field of abstract. It showed like 978 number of articles. The preliminary a basic search showed a large work of literature that are available to allow a work on the systematic review of overall COVID-19. From this broad set of work of literature, we selected the research article with the description on comorbidity on the basis of term comorbidity, multimorbidity in all fields, and COVID-19 in the title abstract. So it gave output of 102 number of article, and after applying the filters like languages and free full text between dates, and it gives the output of output of 36 number of article which are peer reviewed only for screening, so that we consider the complete work of literature. Now this is the process of a predefined search term determined the keywords in multiple combination. The literature was systematically searched using the PubMed, and screening of the article was first based on the title and keyword, and then screening of the after that abstract and full review, the final selection of the systematic review. Inclusion and exclusion criteria. The COVID means the paper selected were based on included on the criteria like COVID-19 diagnosis based on World Health Organization guideline. Studies examined the association specified comorbidities which are of our interest in COVID-19 severity and mortality. The risk estimates reported odds ratio and hazard ratio with 95 confidence interval, 95% confidence interval only they were selected. Article published between that 15 December 2019 and 31st August 2020, peer reviewed and in English language. The exclusion criteria was with the case less than 20 patients, and studies not conducted on human, or they were like review paper, meta-analysis, literature review. Studies reporting unadjusted estimate also were excluded. Simulation studies were not included. Studies only suspected cases, that was also not considered. Tabular and data extraction. We initially screened the title and abstract of all identified article by to reviewer, and after the initial screening of the article and inclusion based on the inclusion criteria, we full text were reviewed, and disagreement were resolved by the discussion to meet a consensus. If the necessary, the third reviewer was consulted in order to reach a consensus. Tabular data is, we extracted the following information: year of publication, date of study, sample size of the patients with COVID-19, author name, country, study design, methodology, and point estimates of hazard ratio, odds ratio, and confidence interval of the risk of dying or adverse outcome in the patient of COVID-19 with each underlying condition. The meta-analysis we performed the random effect model and inverse variance method to estimate the average effect and its precision. To understanding the heterogeneity among the studies, we used I-squared statistic, tau squared, and Cochrane Q test to assess the inter-study heterogeneity. We plotted forest plot for fixed and random effect model with the prediction value of 95% confidence interval. We plotted funnel plot for 95%, 97.5%, 99% confidence interval to testify the publication bias in the meta-analysis of COVID-19. The result shows the size effect of hazard ratio as well as odds ratio of the each 13 disease computed from the meta-analysis. The risk of severity of COVID-19 disease is the highest for the degenerative disease such as coronary heart disease, cardiovascular disease, followed by heart disease and chronic kidney disease, chronic coronary artery disease. Also, diabetes mellitus and hypertension shows high risk for the severity of COVID-19 disease. Compared to these diseases, other diseases such as respiratory diseases, obesity, cancer, and chronic obstructive pulmonary disease shows significant but lower size effect. This is the table of the size effect. You can see the highest is for hazard ratio, that is like 2.3 for coronary heart disease, and that also you for you can see like 1.4 for comorbidity, 1.2 for diabetes, and it is yeah, you can see. And for the odds ratio, you can see like diabetes also high in odds ratio also, 1.5 1.6 almost, and hypertension 1.6, and this is heart failure 1.62, and yeah, 1.6 for coronary artery disease. This is the summary of the table for that effect size with confidence interval 95%. The conclusion: this this adds to previous evidence on the high risk of the death of and older people. Further research is necessary to understand the origin of this risk differentials. Given the persistence of coronavirus, it is vital to focus mitigation campaign on the population at high risk of the fatal outcomes. We also need a stronger public health campaign aimed at reducing the prevalence of obesity, diabetes, hypertension, and their comorbidities. This condition may increase the susceptibility of the Indian population to the COVID and cause rapid progression in severe states of the disease and death. Thank you.
Okay, thank you very much for the nice presentation. And if there are any questions and other, please note them down. We'll move to the next presenter. Ujwal, are you ready?
Yes, sir. Yes, sir.
Yes, please upload and then start your presentation.
Now it is visible?
Not yet, not yet. Yes, it is. Yeah, you can click the, yeah, PPT Soccer, yeah.
Now, sir, it
Wait a minute, not
is
yet.
visible, everyone?
Not yet. We can see the screen, but it is not the full screen yet. I think your network must be a little slow.
Switch off the video, sir.
Yeah,
So it
okay, is
will-
ready? आ गया. Go ahead, go ahead.
Okay, good afternoon, all. Today I discuss the childhood mortality higher in urban, poor, and rural India. Basically, this is the non-pandemic period. There is a lot of challenges of mortality situation between urban, poor, and rural India. So most of the question come from the why the urban poor is more vulnerable than the rural India. The question come from the if the health situation is between the urban poor and rural residents. So in that situation, my topic is follow the health situation between urban poor and rural. So regarding the identification of urban poor, in difference and mortality challenges to paradox because those are urban poor people, they are not good health facility. Similarly, the rural poor people, they are despite for the health disparity because they have a lack of availability, lack of health care. And similarly, another thing is that the migration from rural to urban area has resulted in rapid growth in urban population and slum. This slum population faster great because of the health hazards and also pollution increasing, overcrowding, environmental pollution. So similarly, another thing that the mortality rates of living urban slum population very high level than the other non-poor population also very high level because of the low awareness, irregular recommended health facility, and high cost of health services and poor accessibility. Because poor people not have sufficient cost and also not their health knowledge about the pandemic, non-pandemic situation. Similarly, the poor not only have the high exposure health threats, but also they are often socially and financially important because the socially they are not exposed to mass media, not better education, and also early age and marriage more common the urban poor people. Similarly, I don't think the financial barrier more common in urban and rural because the poor become poorer and rich become richer. This is situation increasing the mortality rate in India from the 2 period. Similarly, the today health inequality strongly influence the lack of irregular private sector and lack of investment of public sector. High cost of health expenditure among public sector and also private sector among the barrier of urban India. Similarly, the health facility in private sector are not accessible to the poor because of the high cost and one of the important challenges increasing day by day. So that situation come from the situation of mortality among the urban poor and rural area. So is the child mortality the higher among the poor than the rural residents? So from the criteria, the present paper identify the child mortality situation by the urban poor and rural residents in India by using the 2 round of data 2005-6 and 2015-16 which is held by NFHS in Mumbai. So methodology basically for the economic purpose, it is used the standardized concentration index for measurement of the inequality among the urban poor and rural both. Similarly, also use mortality by the life table estimation method for the urban poor and rural residents, and Cox proportion hazard model also used for the adjusted by socioeconomic and demographic variable, and finally the predictive probability also used for the interaction affected how much decline the urban mortality situation among the urban poor and rural India. This is the best method identify the factor also. So among the important finding that the situation mortality urban poor and rural in 2005-6 the mortality very high level urban poor and also rural, but the 2015-16 the mortality level decline both urban poor and rural, but the difference between urban poor and rural not decline, it is very narrowed down because of the slum population increasing the day by day in urban area. Thus similar, thus the mortality also increasing urban slum. Similarly, rural population also very high level. They are not better benefit their health facility. They are not medical available. Not if we found the facial analysis to statewide, so it is also found that 2005-6 the most of the mortality situation found the urban India mainly central and northeastern part, and also rural India mainly similarly same situation mainly northeastern, some part of the southern and also mainly central part of India. But 2015-16 It is also found mainly central part of the India, urban poor. Similarly, same figure found the rural India, mainly Bihar, UP, and Odisha, high level of child mortality, urban poor, rural. But situation under 5 mortality, both are the same. Urban poor 2005-6 and rural India 2005 to 5-6, central part and northeastern part of the India. Only difference found that the urban poor mortality increasing in northern and southern part, mainly Jammu Kashmir and some of the Kerala, Tamil Nadu, because of the high urban population in this area. But the rural population in this area, mainly Jammu Kashmir and Kerala, Tamil Nadu, these are not, because the rural population not big in this area. We only high mortality found the central part, UP and Odisha, Bihar, this area. So similarly, same figure, the concentration index among the urban poor and rural India also found that the situation of the urban poor, it is moved from the disadvantaged group to advantage group from 2005 to 2015-16, but the inequality not so increasing. It is also declined. The rural population, the disadvantaged group also increasing, and is more consistent the inequality rural than the urban poor. Most of the central and eastern part of the India very high level of inequality of child mortality, because the poor people not better benefits. Similarly, rural poor people not financial barrier, not too much cost of the health facility, and not medical attended. This is increasing the day by day inequality, also widening the gap between urban poor and rural India mortality situation in India. Similarly, found the demographic factor, the maternal character of the birth, found that the urban poor people, those mother below 18 age, a high level of mortality than the 20 to 29 age group. Reason behind that, the rural and urban poor people, the early age marriage more common in the rural area as well urban area. Thus, the mortality also increasing because early age marriage, high level pregnancy below 19. Rural 30 upper the mortality also increasing because the birth order also increasing in rural area than the urban poor. Thus, the mortality also increasing. The same region when the mother have no marriage more common. Mother, thus the mortality of mother have the no education, but the mortality situation very high because the rural area not too much facility of the advantage. Thus the mortality increasing the day by day urban. In 2015-16, there is a decline mortality between urban poor and rural area, as well higher education or no education. Both are negligible difference. Similarly, found the important criteria that mortality rate, role of police preventing mortality and delivery sector. There are two important figure identified. One is that the rural area high level of mortality, home public as well private sector, because it is more common, because the rural area not so much facility, and also most of the part takes place in the home without medical health facility. Thus the mortality loss increasing. But the situation of the urban poor also increasing because region behind the high level of private sector and also the public sector, significant cost. This is the increasing the mortality urban poor. Urban poor people not benefit their health facility because of the they are despite from the economic value. Thus the most of the birth take place in the home and increasing the mortality in home delivery. So also found that the ratio also increasing the then the urban poor. Infant mortality example that 0.25 to 34 is 0.74 hazard, or the rural 0.76. Similarly, they are found under 5 mortality 0.85 hazard ratio for urban poor 0.76 and the rural. Similarly, the mother have the birth interval 24 to 24/7 lower than the those mother have 24 month. It also declined the more than 48 interval. And also important finding that the mother education, those have no education, higher level of mortality risk than the no education, as well as infant at under 5 mortality. Similarly, further figure found the urban poor and rural. The sex of the child also found that female child is more risky mortality than the male child. A religion also Muslim people also very high risk the mortality than the Hindu population. So percentage change predicted probably also found that the urban poor mortality declined 21.5%, while the rural population declined 28.9%. The decline rate in mortality in urban poor very low level than the rural India because of the high disparity of urban poor and also economic inequality also increasing and also health significant cost and medical assistance delivery without no facility also increasing. Thus the urban poor mortality not so declined in 2015-16 still increasing also attached to rural population. So about the we are also conclusion from that the child mortality rate in India has declined considerably both urban poor and rural India. It is because of the new develop improvement agriculture also medicine facility and also information technology. And finding also suggested that the baby which particularly belonging to rural residents significantly higher risk of the death than those of the rural population. And it is because of the huge disparity between urban poor and rural residents. Similarly, economic inequality encouraging the rural as urban because of the utilization of maternal service direct and significant cost, despite health facility and financial barrier also important cause because those are people they are better benefit by the agriculture because the urban poor people they are not better benefit from the agriculture. They are despite from the agriculture facility, which is the one advantage of the rural population. And also found the disparity between urban poor and rural much more than the disparity between rural poor people because the urban poor children more vulnerable but the not to die the rural population but the rural poor population very high level mortality than the slum population because the slum hazardous population increase and also overcrowding more in common for the disadvantaged condition of the child mortality. Similarly, low child mortality as urban India compared to the rural India mainly come from the significant cost. There is minimum no protection, no financial protection for the family for expenditure health facility and from the above figure, it also need to the policy to remove the inequality and socioeconomic encouraging the female literacy, which not only reduce the mortality but also reduce the poverty. So encouraging the I need to better focus for the central part mainly Uttar Pradesh, Madhya Pradesh, Rajasthan, and some part of the southern mainly Andhra Pradesh and Odisha because the urban poor population increasing the day by day this state and also health condition very abnormal and also health disparity continue increasing growth by day and thus that need to take care of this state of India. So it is also a limitation that the non-availability information of the environmental factor because it also hygienic climate rainfall, one of the important criteria of a decline of mortality and also childhood character. And another important finding that the urban air pollution not take. It is also one of the important because WHO suggested the developing country indoor air pollution 2 million deaths annually under 5 children because urban air pollution very high risk in the urban area. But this study did not take this very well. So this is the main, this is very important. Thank you.
Okay, thank you for the nice presentation and the timely within the time limit. Okay, so I will invite the next paper. The next presenter will be Sadaf. The title of the paper is Examining the Association Between Socioeconomic Components and COVID-19 Fatalities in India. Can you upload? Sadaf, unmute करके Can you unmute yourself? Sadaf? Just hello. What about Ronak? Are you ready?
Hello, sir. This is Rashmi. I will be presenting. Ronak Paul is a co-author of the paper.
Oh, okay. Because this Sadaf is not around. Okay, whenever he comes in, we will maybe after this. So I will invite Rasmi to present on behalf of the Ronak and Rasmi. This is the joint paper. If you are ready, she will be presenting on vulnerability factors of pre-existing under 5 childhood morbidity in Bangladesh amidst the COVID pandemic. Please go ahead. Please
Yes,
go
sir. Screen is visible, sir? Screen is
Yes,
visible?
yes.
Okay, okay.
Go ahead.
Good afternoon, one and all present here. This is Rashmi, and I'm going to present under the theme Morbidity and Mortality under Pandemic and Non-Pandemic Period. My topic is to explore the vulnerability factors of pre-existing under 5 childhood morbidity in Bangladesh amidst the COVID-19 pandemic. So basically, COVID-19 outbreak. I think this terminology didn't need any introduction, as it has not only affected more than 200 countries across the globe so far, but in one way or the other, had touched the life of every individual in both developed and developing countries. Today, the present study focuses on one of the densely populated country with 21.8% population below the poverty line, that is Bangladesh. Like any other country, Bangladesh was also not spared from the outbreak of COVID-19 disease. Studies have shown that with poor healthcare system, poverty, and weak economy, Bangladesh has battled to tackle the pandemic situation. Individuals of individual yeah ha- mm, individuals of every age group was found to be vulnerable of this contagious disease due to their it was seen through the studies that elderly were more susceptible to fatality from this disease due to their low immunity to fight against disease, I think. Children were most likely to be spared from the direct mortality status through COVID-19 involvement, according to a UN policy brief. It was found in a study from 118 low and middle income countries by the John Hopkins Bloomberg School of Public Health shows that the indirect effect of reduction in health coverage services during a pandemic can be the reason of 2 million under 5 deaths, and this would be responsible for bringing back the decades of progress across the world. Bangladesh also threatens from the indirect effect of COVID-19 on the children's health, as they still face an alarming situation in under 5 childhood morbidity. Diarrhea and respiratory tract infections, including fever, cough, and breathing problems, are the common diseases that are prevalent across Bangladeshi children. Past evidences has shown the association of these childhood conditions with the exposure, environment, and the background of children. Now, moving on to the objective of the study. With COVID-19, I think the immense pressure is expected on Bangladeshi children who are already facing health-related issues. Although the government had taken different measures to protect the well-being of children, the pandemic has increased the existing inequities and burdened the country with the risk of childhood disease or death. Insightful mitigation strategy to take care under 5 children during and after COVID-19 pandemic has become the need of the hour. Additionally, the most recently released data of Demographic and Health Survey of Bangladesh provides us an opportunity to understand the morbidity condition of under 5 children before the outbreak of COVID-19. So, the present study aims to provide the different vulnerability factors of pre-existing morbidity condition in under 5 Bangladeshi children and relate them with the potential impact of COVID-19 pandemic. Here the data source is Demographic and Health Survey of Bangladesh conducted during 2017 to 18. The analytical sample for this study is 8,398 children under 5 years of age during the survey from mothers aged 15 to 49 years. Basically, Bangladesh Demographic Health Survey collected the information regarding whether the children had suffered from diarrhea, fever, cough, and acute respiratory infection within the 2 weeks before the survey. We have combined these information to make a single variable of morbidity status, which contains 3 categories: children who did not suffer from any of the 4 Morbidities categorized as no condition. Children who have suffered from one morbidity condition is single condition. Children experiencing two or more condition is has been categorized as multimorbidity. Different dependent variables include child-related characteristics, parent-related characteristics, household level factors, and also the season in which the interview was taken, place of residence, and the different administrative division of Bangladesh were considered during this study. The bivariate association was examined using chi-square test for showing the association between under 5 childhood morbidity in Bangladesh with different risk factors, and a multivariate association of morbidity status of children with explanatory variables was shown using relative risk ratio. Here's the descriptive statistics of independent variables. You can see through the percentage of different characteristics which have been taken from child, household, and parents, and also division or administrative division of Bangladesh. And now I will be explaining the results of relative risk ratio. So in order to show effectively the effect of different risk factors, I have summarized all the results into prediction graph at various levels of one variable as the other variable changes. So here the present graph shows that the probability of acquiring single or multiple morbid condition increases with the decreasing age. Here the highest single or morbidity condition is seen at the age of one of child, as it has been found in studies that children at their younger ages can get exposed to contaminated water, soil, and food easily because at these ages they usually crawl and tries to explore the environment. In contrast to this, older ages children who have already moved towards this exposure are well known with the environment and sometimes build an immunity till that age. Moving on to the next prediction graph, this shows the probability of acquiring multimorbidity condition among male is higher, while little change in single morbidity condition is noticed across both gender. While moving on to while noticing the behavior of morbidity status among children in household where water treatment is done, the probability of single morbid condition increases in the household where drinking water is not treated. However, in the case of a household sanitation condition, no change in single morbid condition was noticed across the three categories. Surprisingly, multimorbidity condition was higher in household where sanitation condition was average. The probability of multimorbidity condition increases in the monsoon season among children with a little change in summer and winter season. Children residing in other urban areas shows a higher probability of multimorbid condition. When observing at the administrative division of Bangladesh, a scattered picture was noticed. The probability of multimorbid condition was higher at Rangpur division. A WHO report has also shown that throughout the decade, the poverty in Rangpur has increased and also face a weak healthcare system throughout the years. So this may be the probable reason for such deteriorated multimorbidity condition in Rangpur. Now moving on to discussion. Although children are not the face of the COVID-19 pandemic, the impact of this universal crisis can be lifelong for them. COVID-19 mitigation strategies have usually enforced the social distancing and isolation measures. However, such strategies may sometimes disrupt the life-saving health services. Adding to this, different vulnerability factors may also affect these strategies. Present study found a strong effect of age on the incidence of these morbidity conditions, and these results are consistent with the previous Bangladesh studies too. Although the household sanitation condition was not much effect on the morbidity status of children, but daily hygiene habits should be promoted among individuals. Their importance was also visible in the study when the household daily drinking water treatment was significantly associated with the morbidity condition of children. A reason-wise mitigation strategy should also be promoted to curb the effect of morbidity condition among the children. Although these vulnerability factors were found to be affecting children before the pandemic period, but the COVID-19 situation can even worse the situation. So more attention is required to mitigate these childhood conditions. the strength of our study is that it is backed with the recent national level data of under 5 children in Bangladesh, which will help us to evaluate the situation just before the pandemic. Our study will also help the policymakers to explore different mitigation strategies that will be carried in the future too. Limitation, this study also includes few limitations as it is a cross-sectional study, so it gives only a cross-sectional view of the scenario, and the morbidity incidence was evaluated from the information provided by women, which may include recall bias. And lastly, concluding, the nationwide lockdown due to COVID-19 pandemic had not only isolated the people from physical communication, but also disrupted the healthcare facilities to care for the pre-existing morbidity condition among Bangladeshi children. During the pandemic, it was found that the access of regular healthcare services and continuity of care become worsened. So, our study urges a greater investment by the government to mitigate the adverse effect of pandemic and to enhance the programs which can reduce the effect of vulnerability factors. Lastly, concluding, I would only like to say that this outbreak has shown the world that even if equipped with highly efficient medical infrastructure, developed countries can also experience extreme stress and battle against the pandemic. On the other hand, there is much to learn from the developing countries like India in terms of preparedness, leadership, and innovation. Thank you.
Okay, thank you, Rashmi, for the nice presentation and also presenting within the time limit. Can you just introduce yourself? Because
Yes, sir.
yeah, you and the co-author, yeah,
Yes,
please
sir.
introduce.
Sir, my name is Rashmi, and the co-author is Ronak Paul.
You are, okay, okay. From which institute or?
Yeah, yes, sir. I'm from IIPS only, International Institute for Population Sciences.
Okay,
We
okay,
are from PhD first year.
okay, okay, okay. Thank you.
Thank you, sir. Thank you.
Yeah. Okay, so I'll request Dr. Sadaf. Are you ready?
Yes, sir.
Okay, yeah, and please introduce yourself also. Yeah, maybe you can introduce your other co-authors also.
Yes, sir. Myself, Dr. Sadav. I'm an assistant professor in Veer Kumar Singh University, Ara, Bihar. And my co-author is
Okay.
Dr. Khurshid Ahmed Khan. He's also an assistant professor in Samastipur College, Samastipur, LNMU, Darbhanga.
Okay, okay. Welcome to this session. Yeah, you can share
Thank you, sir.
the PPT and
Yes.
then start your presentation. Yeah.
Okay, sir. So now my PPT is visible, sir?
Yes, yes. You can click that slideshow. Make
Okay,
it
sir.
so that yeah. Yes, yes. Good,
Okay,
good.
okay, okay, sir. So good afternoon to all of you. Myself, Dr. Sadaf here. I'm going to present on the topic of examining the association between socio-economic components and COVID-19 fatalities in India. So as we know that the global pandemic caused by coronavirus COVID-19 has become a global health concern for its unpredictable nature and lack of adequate medicines. So since no medicine is available yet to treat this novel disease, although the several vaccines are now has introduced, but still the medicines is not available yet to treat this novel disease. The rate of mortality due to COVID-19 is rising worldwide from its emergence in December 2019. So, however, according to World Health Organization, the rate of COVID-19, especially it depends on the immune system of a person, as most of the COVID-19 infected persons have experienced mild to moderate respiratory unwellness and cured without required a special treatment. So it is considering its impact of COVID-19 on overall human health well-being, the United Nations declared the disease as a social, human, economic crisis, because I think it is a more than a medical emergency. It indirectly or directly affects the social, human, economic conditions of a human being. So it has created an anticipated global public health crisis that is spreading rapidly in India as well, and it's posing a serious threat to 1,350 million persons. So India was the second highest COVID-19 affected country in the world with 2.1 million cases by 11th August 2020. So India is a diverse country in terms of physical, in terms of cultural, in terms of social, and in terms of economic factors. So the socio-economic factors plays a crucial role in shaping the pattern of COVID-19 positive cases as well as the deaths related to COVID-19 in India. So here my objective of my study are to analyze the growth pattern and nature of COVID-19 in states of India. And second one is to identify the main factors which have influenced the growth pattern of COVID-19 in the state of India. So basically the study is based on secondary sources of data, and the data regarding daily infected cases has been collected from COVID-19 Indian portal and official website of Ministry of Health and Family Welfare as of 28th of February 2021. 25th February 2021. So I have collected the cumulative data of COVID-19 cases as well as deaths related to COVID-19 in different states of India as well as Union Territories of India. Socioeconomic data of different states has been collected from the Census of India, and the state has been taken as the unit of analysis for analyzing the relationship between COVID-19 cases as well as deaths to the socioeconomic factors. Multivariate linear regression model has been used, and for examining how the spread of COVID-19 differs from one state to others, a cluster analysis has been made at the state level. So here the list of indicators, or I have chosen two different dependent variables. First one is infected person per lakh population, and second one is number of deaths per lakh population. And in independent variables, I have taken four variables. First one is urbanization, and second one is population density, third one is poverty or percentage of population below poverty line in different states, fourth one is percentage of elderly population to total population. So here I have taken the data of infected person, cumulative data of infected person, and I have normalized all the data with the help of standard deviation, and have categorized all the data with the help of mean and standard deviation into three different categories. So here the high infected cases are found in Chandigarh, Delhi, Goa, Kerala, Maharashtra, Puducherry, and Andhra Pradesh as of 25th February 2021. And number of deaths are more in the states of Chandigarh or Union Territory of Chandigarh, Delhi, Goa, Maharashtra, Puducherry. Level of urbanization, on the basis of census data, Chandigarh, Delhi, Goa, Lakshadweep, Puducherry, Mizoram, and Tamil Nadu, these are the urbanized states or union territories in India. On population density, I have taken the population density in socioeconomic variables, because population density and urbanization both are very important factors which are influencing the COVID-19 spread as well as the death, because urbanization and population density leads to increase the interaction among the people, so that may be influence the COVID-19 spreading rate. Here the Chandigarh, Delhi, Lakshadweep, Puducherry are the highly dense, population dense state or union territories, and I have taken the data of poverty where Uttar Pradesh, Odisha, Manipur, Madhya Pradesh, Jharkhand, Chhattisgarh, Assam, Bihar, and Arunachal Pradesh. These are the states which are showing the higher percentage of poor people which are living in the below poverty line. And percentage of elderly population, this is also very important variable and factor, because aging factors is also found crucial in controlling the COVID-19 deaths and as well as the spreading, because the high number of deaths and infection in Italy, Spain, and other European countries may be linked with the demographic structure of the country, especially elderly population. So these are the states like in Union territories like Andaman, Nicobar, Haryana, Goa, Himachal Pradesh, Maharashtra, Tamil Nadu, Kerala, Odisha, Puducherry, Punjab, and Uttarakhand. These states and Union territories are showing the higher percentage of elderly population in India. So I've done the cluster analysis on the basis of the variables like urbanization, population density, poverty, and percentage of elderly population, total population. So there are 4 clusters: cluster 1, cluster 2, cluster 3, and cluster 4. And these clusters are showing the same characteristics of the variables. So here with the help of multivariate regression analysis, I've analyzed and the association between socioeconomic variables and COVID-19 infected cases as well as the deaths. So here we found that the urbanization, population density, and elderly population are closely and significantly related with each other in India, except poverty. Poverty is negatively associated with infected rate and the death related to COVID-19 in India. So here on the basis of t-test, the level of urbanization and infected person per lakh population are significantly related with each other, and the level of urbanization and death per lakh population in different states of India are significantly and closely related with each other. So the study suggests that the selected socioeconomic components, including urban population, population density, poverty, and elderly population, are the key factors in regulating overall casualties of COVID-19 in India. And the distribution of COVID-19 confirmed cases and deaths were found heterogeneous across India. This uneven distribution could be attributed to many socioeconomic factors. For both COVID-19 cases and deaths, the maximum record were documented in the highly urbanized states, and a strong positive association between urbanization as well as the population density and COVID-19 cases as well as the deaths is found in this study, which indicate that these two factors could be the key controlling variables that determine the overall casualties caused by COVID-19 in India. A negative association between poverty and COVID-19 cases and deaths is found in the study. Thank you, sir.
Okay, thank you for the nice presentations and within the time limit.
Thank you, sir.
Yes, yes. Now you all can put on the videos, and I will invite. I think that presentation number 5 is not present till now. Rinshu or Sindhu. Any confirmation from the organizers?
I don't see her here.
Yeah, okay. So should we confirm as absent? Okay, yeah. Okay, the organizers also can note down.
Sir,
Sir,
Manoj.
Yes, yes.
Sir, Manoj.
बोलिए.
Sir, Rinshu is not joining. Rinshu is not joining.
Okay. Confirm, na?
Confirm, na?
Confirm.
Okay, thank you.
Rinshu is not joining, sir.
Okay.
I called her. She is not.
Yeah, okay, so yeah, we have 4 nice presentation on various aspects of morbidity and mortality, and in some of them in the related to COVID-19 pandemic. So I will invite Dr. Sahu to give his remarks and comments on the papers, and then we will open the papers for discussion. Dr. Sahu, to you.
Yeah. So thank you for giving me this opportunity. Yeah, so these 4 papers which were presented in this session were extremely were up to the quality, good quality in nature, but some of the papers which most of the papers have used the secondary data sources for their analysis. I will start from the first one, that is the multimorbidity and severity of COVID-19 disease. In this paper, the Rashid who presented this and stating that doing a literature search and systematic review and meta-analysis, and performed several analysis of different morbidities and how their linkage to the severity of the COVID-19 pandemic. So the peer-reviewed articles they have collected, and after that they did some other techniques of analysis, and as a result of which they found that the risk of severity for COVID-19 disease is the highest for several NCDs, several non-communicable diseases, including the chronic kidney disease, and coronary artery disease. And apart from that, diabetes is also linked, very closely linked, and also hypertension is also linked with COVID-19. But I was worried. I was thinking of this paper. So though they have done these papers of different places of the globe, collected from the different places of the globe, but whether it would have given much more interesting if they could have performed the analysis with a country-specific or region-specific analysis. In that way, it would have given much more emphasis how it varies from one place to another. Coming to the second paper, which was presented on childhood mortality, and it's particularly with two different segments of the population. One is urban poor, and the other one is rural areas. While mentioning the urban poor, so it was stated that particularly by taking the wealth index, the author might have computed the urban poor. And the findings which suggest there is a decreasing trend in infant mortality and also the under 5 mortality, both urban poor as well as rural India. So in two different time points from NFHS 3 to 4. The economic inequalities with respect to under 5 mortality is higher in urban poor than in rural India. And the author has applied the Cox regressions and finding out the possible explanations, possible factors which are closely associated with this under 5 mortality, including the infant mortality. And the interesting thing which was coming out from this paper was that after controlling other predictors, the percentage declined mortality in rural areas was higher than the urban poor, but inequality is more widened in urban poor, particularly in India. But the question arises here: the computations which the author has attempted to calculate the infant mortality rate and under 5 mortality rate. I was worried how these things have been computed, whether the author has calculated it is the percent of infant deaths or under 5 deaths. So similarly, when it was attempted to compute the by using the this hazard ratio, relative risk ratios was attempted, but the title was showing that the infant mortality rate. So I was thinking, so whether it is the infant deaths or actually infant mortality rate. So similarly, under 5 mortality rate or it is under 5 deaths. So that rectification can be done. And when it was controlled, there are some of the possible predictors which could have been undertaken. So considering that the birth interval, particularly what was what is the age or the months of the previous birth to the succeeding birth. So as a result of which, so that can be controlled, because if birth interval between the two pregnancies or the interval between two pregnancies many a time plays an important role or become an important risk factor for infant and under 5 deaths. Apart from that, the age at birth of the mother's age at birth, so that also plays an important risk factor for this study. So I don't think so the author have considered these variables. So if this variable would have been considered, that will give a better picture. Coming to the third presentation, which was on Bangladesh. vulnerability factors of the pre-existing under 5 mortality, under 5 childhood mortality in Bangladesh. The authors presented this paper considering the secondary Bangladesh DHS, and where the like our Indian DHS, they have asked the questions before 2 weeks. What have before 2 weeks of the survey? So what are the different problems have happened to the child? So like the diarrhea, fever, cough, and acute respiratory infection. So these are the 4 questions which have been collected in the Bangladesh DHS. And here, so the authors have beautifully analyzed the background of the study, and also in the concluding remark when they presented, that was very lucidly presented the linkages of the COVID-19 pandemic. But the major concern of this paper is that the linkages with COVID-19 pandemic with the associated morbidities have not been established in the statistical analysis. So that is the major worry. But the concern is that when the out of these four morbidities, when the authors have been grouped into 3 categories, like the child do not have any morbidity, someone has only single morbidity, and someone has more than 1 morbidities. But many a time it happens that if a child is suffered from diarrhea, then it is more likely to have he should suffer. He might have suffered from fever. So there are some linkages are there. So with diarrhea, with fever, and even if some cold and cough with fever, and many a time if it is ARI with fever. So it is if in the background it could have been shown how this relations between each of the morbidities have been happened, and further the comorbidities or multimorbidities have been computed. So that could, if the one analysis could have been performed before proceeding the analysis, that would give the readers of the paper would be clear. Apart from that, the authors performed, I think, the multinomial logistic regressions, where they have presented the relative risk ratios. So where so many a time the things which is emerged, particularly the seasonality of the DGS, many a time plays an important role. The seasonality in the sense that particularly these like diarrhea or the fever, it is more likely during the monsoon period, particularly in the month of July or August or June. So if seasonality things, if they could have conducted, that would give us a very clear picture. Apart from that, the concern is that the linkage with COVID-19, though the lot of explanations have been given, but statistically it was not presented. But to maintain, to strengthen the paper, one could see how the hand washing has been mentioned and different sanitary behaviors have been practiced in the households, and those things would have been added analysis which could substantiate to the title. Otherwise, whatever the analysis have been performed, it is more or less the to find out the factors of different childhood morbidities in Bangladesh. Coming to the last presentation, so last presentation which attempts to understand the association or to examine the association between socioeconomic components and COVID-19 fatalities in India. But when we talk for the fatalities, but in the analysis, so there are not only the fatalities, but also the infections has also been carried out, or the analysis has been performed. So accordingly, the title may be modified. So it should be so fatalities words should be modified. So in this paper, the authors has 2 broad specific objectives. One is to find out the different how this varies by the states, and the different factors are responsible for this. And author have attempted the linear logistic regressions and also the cluster analysis. And here, so using the COVID-19.org, COVID-19india.org website, the authors might have considered got the informations, and accordingly they have established which are the by the end of February. So what is the high or the pandemic is more worse, and which are the states and where it is low. So, in this paper, they attempted particularly the four specific indicators to find out the causal linkages of the infections and also the fatalities, like the percent urban, poor, and elderly, percent elderly, and also the population density. But the thing is that only thing concerned is that from the analysis they found that poverty and the COVID-19 infections or the fatalities are negatively related. But many a time it happens that so many a time those migrants who are from returning from the urban areas to the rural areas, as a result of which the things have been spread over, the COVID-19 have been spread over to the different parts of the country. So in that circumstances, so if poverty many a time plays an important role, so particularly those poor migrants going to from the urban metropolitan cities to the rural belts. So in that circumstances, so they are the infected. So as a result of which is that infections have been spread over, but the study did not find that. So one of the important variable which could have been considered here, so like what are the health conditions of the population, like whether how many people are having the different chronic conditions, and also the comorbidities, who are also the major risk factors for this pandemic. So that variable have not been considered. If that variable would have been considered, that would give a better picture of this paper. So thank you for this opportunity. So now it is to the chair.
Okay. Thank you, Dr. Sahu, for bringing out nicely the strength and the weaknesses of each of the paper. And if, I hope that the presenters will keep note of that. And if they also want to respond to some of his points, we can give time for that. Since we still have almost about 10 minutes, the papers are open for discussions. If there are any, please start asking the clarification or anything, so that the authors can
unmute and ask question. Okay.
I think they can switch on their video. I'll
yes. Please switch on your videos, whoever is attending this session. And if there are any, even the presenters can ask question for the other papers too. Okay, anyone? Not only everybody. If there are any specific questions to any of the papers, it is open. We still have about 7 minutes. Okay, just one question to the Ronak, and also this number 2 is the childhood mortality. No? This what is the age group you're considering? Is it under 5 in case of Ujwal, and also in case of the Ronak? When you are comparing infant mortality and under 5, are you separating out the infant mortality in the under 5? Usually we take infant mortality in under 5. I mean, it includes that. But when you are doing the comparison of the infant mortality and under 5, do you separate out the, yeah.
And 0 to 11 month for infant and 0 to 59 for under 5.
0 to?
0 to 59 for under 5.
Okay. So, okay. I just want you to I hope you understand why I'm asking that.
Yes, sir. Yes, sir.
Yeah. Because under 5 means it includes your infant mortality also. So
yes, sir.
Yeah. Okay. Otherwise, sometimes people use another term, that is the child mortality, where it can be 1 to 4.
1 to 4.
Yeah, because that gives a better comparative picture. Anyway, in
Yes,
case
sir.
of visual
For
also, you are
0 to 1 and
yeah. In your case also, you consider that or not?
yes, I consider, sir.
Okay. Fine. Are there any other questions? Anyone can ask. Anyone, please unmute yourself and ask. Yeah. We still have about 5 minutes. Any of the faculty members also can give their views on some of the papers. Nobody? Otherwise, I'm going to close the session. Salini?
Yes, sir.
From your side, do you want any clarification from the presenters?
No, sir, not right now.
Okay. Pretty, I think we are done then.
Okay.
Can we close?
Yeah, I think all presentations were good and very relevant in this session. And I want to thank chairperson and also discussant for giving this much time. And also I thank to Shalini, who is making notes as a reporter. So I think we can move for another sessions after some time. So we are just before closing because we do not have one participant. So we may close then. Yeah.
Okay.
Yes,
Okay, thank you all and all the best to all of you.
Thank you,
Okay.
sir.
Okay, thank you, sir.
Yeah, okay, bye.
Thank you, sir.
Yeah, bye. Yeah.
Thank you, sir. Thank you.